So good morning, good evening, and good night to everyone from across the globe that's joining us for this edition of the EIOC. We're going to be talking about early and metastatic bladder cancer management, which, as you know, there's been an explosion of data in the last couple of years within this realm. My name is Shahina Dawood. I'm a consultant medical oncologist coming to you all the way from the very sunny, very bright, and very safe United Arab Emirates. And I'm joined today by some spectacular faculty from across the region, and I'm going to allow them to introduce themselves. Dr. Abdul Rahman Zar.
Yeah, thank you, Dr. Shahina. I'm Dr. Abdurrahman Zar, consultant medical oncologist in National Cancer Center of Care and Research in Doha, Qatar. Um, I'm doing GU, lung, and head and neck. Uh, yes, so I will be here with Dr. Shahina today.
Dalia.
Salam alaikum everyone. This is Dalia Shurbagi, Medical Oncology, SSMC Abu Dhabi. Thank you.
Jamila.
Hi, my name is Dr. Jamila Rir Omar. I'm a consultant medical oncologist at Royal Hospital National Oncology Center. So I'm doing the two sites, GU and Gynae. Thank you for inviting me.
Two very opposite sides, Jamila.
No, all of them in the same place,
In the
Bilbis.
same place. And Dr. Muhammad Ashur.
Assalamu alaikum, Muhammad Ashur, consultant medical oncology, Kuwait Cancer Control Center.
All right, now without further ado, I'm going to share my slides. And like I said, we will be discussing both advanced as well as early stage bladder cancer. So let's start off by just looking at the early stage breast cancer. We're going to start off with muscle invasive bladder cancer and then go on to the advanced bladder cancer setting. We know that patients with MIBC, usually they present with painless hematuria, irritative symptoms, bone pain and flank pain. They're usually worked up in an appropriate manner. TURBT is usually the first line of management by our urologist, and then obviously it goes on from there. You then go on to the staging and grading of the disease, and then finally making those treatment decisions. We also know that when we look at the TNM and which you have both UICC and AGCC classification systems, we know that a lot of these patients are when we're talking about muscle invasive bladder cancer, we're talking about stage 2, 3, as well as 4A and 4B. We know that the care team involved in the use of, in terms of treating patients with muscle invasive bladder cancer is really a multidisciplinary tumor team, including your medical oncologist, pathologist, urologist, as well as radiation oncologist, to determine that individualized therapeutic plan, which could include so many different modalities, including surgery, including a partial cystectomy, urinary diversion, incorporating neoadjuvant chemotherapy plus minus immunotherapy, and then, of course, adjuvant therapy, and then we should not forget radiation therapy. Now, there's been a trend towards trying to look at bladder preservation strategies as an alternative treatment for patients with eligible patients for muscle invasive bladder cancer. And I wanted to really ask that question first. So if everybody could just put on their videos so I can actually see and call upon you. Otherwise, I will not be able to see who is online. So Dalia, put on your video. Muhammad, put on your video. Abdul Rahman Zar. I know Jamila is driving home, so she'll put on her video very soon. But Dr. Dalia, how often do you see muscle invasive bladder cancer? Because at least for me, I see it, but I don't see it as often as some of the other malignancies in the country. So how often are you actually seeing muscle invasive bladder cancer?
Yeah, I think it's not common in UAE as in other areas in the Middle East. Like, for example, in Egypt, I used to work there, and we used to have bladder cancer, both muscle invasive and metastatic, a lot of patients every day in the clinic. But honestly, here in UAE, it's not like that. The incidence is less than in Egypt, for example. But yes, we see muscle invasive. Most of the patients actually they are early, but we have a quite good number of patients with muscle invasive as well.
Dr. Muhammad Ashur, do you see a lot of muscle invasive bladder cancers?
I think we have as regard, we are only the center in Kuwait and serving about 5 million populations. So we are seeing at least four cases per month. We can
That's quite a
see,
bit.
yeah, we have this week we have two cases. Until now, we have two cases. We saw upper uterine invasive bladder cancer, two cases we saw this week. And I think we are facing frequently this in diagnosis in clinical practice.
Okay. So, Dr. Jamila, you're there in Oman. Do patients generally agree for surgery when they've got muscle invasive bladder cancer? Because in our part of the world, there's always this thing, no, we don't want our bladders to be removed. Is there any strategy for, in the therapeutic plan to preserve the bladder, or is it you're finding it that patients are agreeable to a cystectomy?
Yeah, that is true. It's the same thing here in Oman. And always when they're referring from their urologist, they will say patient refused or patient unfit. And
Okay.
actually, small number of them, when they go abroad, they get the cystectomy, the radical cystectomy done. They get somehow convinced. But the majority of patients, yes, they refuse and they prefer to do something different to preserve their bladder. Yeah.
And Dr. Abdurrahman, are you
Yeah.
finding that patients want cystectomies versus bladder preservation strategies?
Yeah, actually, we are getting because again, this is like Dr. Ashur he mentioned. We have single center. We discuss all the cases, so we receive good number of cases. So, like in our center, at least muscle invasive, we see something between 8 to 15 cases per year. And we like last year I have four patient on new adjuvant approach, which is we use this new Niagara protocol. 1/3 of them they decline after, particularly after achieving good response. Initially they agree for because we have local and expat. So local, usually we have little issue with them when we speak about radical cystectomy. They ask for second opinion, but others they usually agree, for
Okay.
cystectomy. Yeah, yeah.
So let's go through some of the interesting studies that we have incorporating immunotherapy as well as some other strategies in our patients with muscle invasive bladder cancer. And I think one of the most interesting studies that I think came out last year was the IMvigor 011 trial. If you remember, this found itself in the New England Journal of Medicine last year after its presentation at ESMO, and it became the paper of the year, in which they took patients with muscle invasive bladder cancers who had undergone a radical mastectomy within 6 to 24 weeks. These patients had to have histologically confirmed PT2 to PT4A or node positive bladder cancer with no evidence of radiographic disease. They could have received prior neoadjuvant chemotherapy. And what they essentially did was, in the post-op setting, now I haven't even started to talk about pre-op, but in the post-op setting, they had ctDNA monitoring, and they did it for 1 year post-cystectomy. And essentially what they did was, if a patient had ctDNA negative disease, there was no treatment in the adjuvant setting. But if they had ctDNA positive disease at any time point in that 1 year, so it could have been halfway through, or maybe later on they got ctDNA positive disease, they were randomized to get either atezo or placebo. And interestingly, and the primary endpoint was, of course, DFS with key secondary endpoints of overall survivals. These were the patient demographics and key characteristics. About 167 patients in the atezo arm, 83 patients in the placebo arm for those with ctDNA positive disease, while you had about 357 patients who had ctDNA negative disease. Now you can see about half of these patients had received prior neoadjuvant therapy. And then you can see the time from the time from cystectomy to having your first ctDNA positive sample, less than 20 weeks, less than 20 weeks was about 70% of patients, and more than 20 weeks was about 30% of patients. And you can see the patients who achieved a ctDNA positive status at the initial test was about 60%, and its subsequent visits was about 40%. So these patients are pretty much high-risk patients. And when you look at the DFS, in those patients who were tested ctDNA positive, which was the investigator assessed DFS, you can see a very nice separation of the Kaplan-Meier curves. The DFS improves from 4.8 months to 9.9 months, and this resulted in a 30% reduction in the risk of recurrence of disease. And when you looked at the overall survival in the ctDNA positive cohort, again, 32 months in the atezo arm versus 21 months in the placebo arm. Again, a nice separation in the Kaplan-Meier curves, and the median follow-up was only 16 months. So again, this was very early that they were actually seeing that difference. When you're looking at the forest plot, it's very, very interesting. It didn't matter whether you'd received prior neoadjuvant chemotherapy or not. It didn't really matter if whatever your PD-L1 status was, although it seemed to work more in those patients with a higher PD-L1 status. And it seemed to work more in those patients who are having ctDNA upfront rather than developing a ctDNA positive disease much, much later on. And it didn't really matter what type of MRD testing you are actually seeing. So, Dr. Abdul Rahman, have you
Yes.
started incorporating ctDNA testing in your practice based on these results of the mVigor study? Because this is the first time, I think, this is an interventional study. This is the first time, I think, in any malignancy where when you get MRD positive disease, you're now able to say, look, the ctDNA is positive. Let's give some immunotherapy. There's not only a DFS advantage, there's an OS advantage for these patients.
Yeah, thank you very much. It's an interesting study, I think. But the issue is in this study, they did circulating DNA every 6 weeks, which is probably what we use for circulating DNA, Signatera, which is pretty expensive. And I think already there is a debate. I mean, what is the benefit? Now, the question is that if patient, like particularly the benefit was seen more in the less than 20 week when it is positive, and then patient who have PT2 tumor, they had a hazard ratio of 0.25, really benefited. But the patient who received already new adjuvant treatment,
But the
I think,
numbers are small, Dr. Abdurrahman, for the
yeah,
PT2.
I
The
mean,
numbers are very small. So I think you can't
uh,
really make out. I mean, and that confidence interval is super wide. So
Yeah, so I
crossing
mean,
one.
yeah, but again, in this, if I see patient who underwent, like here we can say 50% who received new adjuvant and 50% didn't receive anything in upfront surgery. And when you see patient with upfront T3 T4 on lymph node positive and ctDNA is negative, is anyone can say that I will not give adjuvant chemotherapy or immunotherapy? I think it is very challenging and very difficult. So I think still in our practice, this is not the way we go. If patient receive new adjuvant chemotherapy without immuno and he has residual disease, we give them those patient immunotherapy. But if patient receive new adjuvant chemoimmunotherapy and then he has a residual disease, we continue the immunotherapy as what they did in Niagara. And
So
upfront, yeah,
if I may, because we're going to come to that. So that's why I'm
definitely.
interrupting you. But
Okay.
Jamila, in Oman, say suppose cost was not an issue and everything was available. Is this a strategy that you would employ for your patients? This is the first time this study is actually showing that if you have ctDNA positive disease, you need to intervene. Otherwise, these patients do very badly. So what are your thoughts here very quickly? Because we have a long way to go in terms of all the questions I need to ask.
Yeah, I think it is very interesting, and it's going to be it's going to be one of the end. I mean, the tools to use not only the images, the circulating tumor DNA, but now to use it in the routine practice. I think it is only prognostic, but of course it will be introduced, but still it is not available. And
Jamila, how is it only prognostic? This data actually tells you it's also predictive of benefit to
absolutely,
immunotherapy. It was an interventional
yeah.
study.
Yeah, I mean, but it will not affect. I don't have access to it, and even if I do, and it's negative, it will not change. As Dr. Abdurrahman said, if the patient is as per previous trials for new adjuvant, and we have also for minimum residual disease or pathological positive, we are doing nivolumab, have access to nivolumab. Still, I mean, yeah, it's not. I
Okay.
hope.
All
Yeah.
right. Okay, so now if you look at the subgroup analysis for those patients based on the timing of the ctDNA positive test, you can see those that had ctDNA positive test at initial testing as well as subsequent testing benefited from the use of immunotherapy. You can see that it also atezolizumab cleared the ctDNA. You know, what I see from this trial, at least for me, it's telling me immunotherapy is important in these patients with
Absolutely.
bladder cancer. That's what it's telling me. Whether you
Yes.
do it in the adjuvant or the neoadjuvant setting, it's telling me for the first time that immunotherapy works and it works very well, irrespective of the PD-L1. Now, when you look at those patients with who are ctDNA negative, you're seeing spectacular results in terms of the DFS and the OS. And what this tells me is that perhaps we might need to start subgrouping patients, not maybe not tomorrow in practice, but subgrouping patients to see who actually needs immunotherapy, because not everyone needs it. This is the era of personalized medicine. So Dalia, have you, in one or two sentences max, because we have a lot to cover, have you started incorporating ctDNA testing in your practice?
No, I honestly no, I did not.
Okay,
It
so
is very important to trial, and it is positive only in the ctDNA positive. Yes, I agree, but I didn't start yet using it.
okay. So then we have the Checkmate 274 study. This was also a very, very interesting trial. Checkmate 274 took patients with again, these patients had not received, or these patients had not received prior immunotherapy, but they were YPT2, YPT4A, or node positive muscle invasive bladder cancer who had received neoadjuvant chemotherapy that was cisplatin based. Um, and they also had you had a subgroup of patients without prior neoadjuvant cisplatin chemotherapy because they'd either refused or were ineligible. These patients had radical surgery and then they were randomized to get either adjuvant nivo or placebo, irrespective of the ctDNA. So again, here was a different strategy. Invigor did it based on ctDNA positive or negative disease. Here it was all comers. And you can see in all the randomized patients and in the PD-L1 positive patients, you are seeing a benefit with the use of adjuvant nivolumab, more so in the PD-L1 positive group of patients, 8.4 months to 55.5 months improvement in that DFS. And when you're looking at it in all randomized and the PD-L1 more than or equal to 1%, again, you can see a really, really good benefit with the use of nivolumab, whether they had received prior neoadjuvant chemotherapy or not. So you can see all randomized patients with muscle invasive bladder cancer and prior cisplatin or without prior cisplatin. And you can see again, both groups of patients were actually benefiting. And the overall survival in terms of the interim, you can see again, there was a very strong trend towards benefiting those patients who had received adjuvant nivolumab. So, Dr. Ashur, do you routinely incorporate adjuvant nivolumab in your practice?
Clearly, we are using nivolumab in adjuvant setting according to the Checkmate 274 without using ctDNA as a predictive or prognostic marker.
Okay, okay. And Dr. Abdurrahman Zar, are you using
Yes.
adjuvant nivolumab? And if so, for whom? Very briefly, please.
Yeah, definitely. We are using for those patients who receive neoadjuvant chemotherapy or without neoadjuvant chemotherapy, but those patients who receive chemoimmunotherapy Niagara protocol, those patients we give them Durva. So patient who have like after new adjuvant chemotherapy. We give to patient PT2 and above, and those who didn't receive those patient T3, T4 lymph node positive patient. Yes, if they are not fit for adjuvant chemotherapy, there is again little bit debate: should we give adjuvant chemotherapy or give Nivo? So I have patient like their renal function is not great, so I give them Nivo.
So I had a patient recently who came to me from another institution, clearly bladder cancer that was advanced, had surgery up front, and then was offered only adjuvant nivolumab, which I thought was not enough in a young patient in his 40s with, advanced bladder cancer who had surgery. Dalia, would you have given this patient chemo plus nivolumab or just nivolumab on its own?
Okay, I think adjuvant chemotherapy post cystectomy, we have a meta-analysis. The advantage of adjuvant chemotherapy came from a meta-analysis. It's not behind, it's not before, it's not a prospective trial. So it's meta-analysis of many of the trial. So there is a benefit of adjuvant chemotherapy. There is no doubt of that. But adjuvant chemotherapy, yes, I would consider it for patient with this group who didn't, with locally advanced disease, especially if they are not cisplatin eligible patient.
So in this trial, in the Checkmate 274 study, there was a subgroup of patients where they actually looked at the ctDNA. This was a translational component of this study. And you can see that in those patients who had ctDNA that was detectable, they did worse than if their ctDNA was not detectable. You can see the median DFS was 5 months in those patients with ctDNA detectable versus the ctDNA undetectable at 52 months. And this was both for DFS as well as overall survival. Here you're looking at the relationship in each of the treatment arms, and you can see that here these dotted lines are patients who are the blue line is Nivo and the orange line is placebo. These were patients who had undetectable ctDNA. They're doing exactly the same. And in those patients who have detectable DNA, the blue line is Nivo, they're still doing better than the placebo group. So do you think, Dr. Ashur, this is the same sort of data that IMvigor is telling us, that if your ctDNA is negative in the adjuvant setting, you don't need immunotherapy. But if your ctDNA is positive, you need immunotherapy, although you're going to do still badly, but better than if you don't get immunotherapy. So Dr. Ashur, what are your thoughts here? Because even in terms of the overall survival, you're seeing a very nice separation in the Kaplan-Meier curves as you see here.
I think the idea to see the minimal residual disease by ctDNA is valid, but still in bladder cancers need more trials and need more data to be evolved as a standard of care for all of us. So we are waiting more of data. We have only one trial, and on the other side, we have post hoc analysis in another trial, showed no difference in survival between groups in ctDNA like in Niagara protocol. So in this setting, it is applied in many diseases, especially in hematologic malignancy. Minimal residual disease now is a standard of care. But in bladder cancer, it needs more times. I cannot apply for all patients. It can be, if it is available in the center, I will use as a tool to my practice, but it is not a decision maker tools.
Okay, so now let's look at some of the perioperative approaches in the management of muscle-invasive bladder cancer. And I think one of the first trials we need to look at is the phase 3 clinical trial, which is the Keynote 905 study. And in the Keynote 905 study, these were adult patients with muscle-invasive bladder cancer. They had a clinical stage T2 and above, so T2 to T4 node negative or node positive disease. They had to have more than 50% urothelial histology. These were specifically, the Keynote 905 was specifically cisplatin ineligible patients or cisplatin declining patients. So it was a specific subgroup of patients, and these patients were randomized in the perioperative setting to get either pembrolizumab alone or pembrolizumab plus enfortumab, and then they underwent surgery. And then post that, in the adjuvant setting, if they got pembrolizumab in the perioperative setting, they got it in the adjuvant setting. If they got pembrolizumab plus enfortumab in the perioperative setting, they went on to get it in that adjuvant setting. So this was the study trial schema. The primary endpoint was event-free survival with key secondary endpoints of overall survival. Now, when you're looking at the baseline characteristics, about 170 patients had the combo arm, while 174 patients was the control arm. And you can see that about 12% of patients had an ECOG performance status of 2, which I found was very interesting because we're usually very worried about adding any antibody drug conjugate or chemotherapy in these patients with a higher or a more poorer performance status. You can see that the majority of these patients were cisplatin ineligible. That's about 80%, while only about 20% were eligible, but they declined cisplatin. You can see about half of these patients had a high CPS score. Almost 80% of these patients had really advanced disease, so T3, T4 type of disease, and about 60% of these patients had a creatinine clearance that ranged between 30 to 60 ml per minute. Now, when you're looking at the primary endpoint in terms of event-free survival, very early separation of the Kaplan-Meier curves favoring the group of patients who are getting enfortumab plus pembro, which was a median event-free survival that was not reached. And you can see the control arm was 15.7 months in terms of that median event-free survival, translating into a 60% reduction in the risk of recurrence of disease. And you can see again in the forest plot, every subgroup of patient is benefiting irrespective of that PD-L1 status. When you look at the overall survival, again, the group of patients getting enfortumab plus pembrolizumab clearly doing better, 50% reduction in the risk of death from disease. And again, in that overall survival, the forest plot, everyone is actually benefiting, again, irrespective of the PD-L1 score. So Jamila, what are your thoughts about the design of this keynote trial? Do you think that that control arm was a fair comparator in this study? Because that's one of the key points that are usually discussed in when we're talking about the keynote trial.
Yeah, actually, it's not, because we are talking about the standard of care. It is a new adjuvant chemotherapy, or as per the meta-analysis, it is the adjuvant chemotherapy. But we have mentioned also before that the immunotherapy with the circulating tumor DNA, really, it is showing that the immunotherapy is really making a difference for these patients. But is it enough? No. It doesn't look that immunotherapy alone for these patients are not enough. Although the circulating tumor DNA also it's showing that the patient who has a good response on immunotherapy, they really do better than the patients who are positive. So I think here only comparing with pembrolizumab, it is, it is not comparing with the standard of care.
So, Dr. Ashur, what are your thoughts here about this particular trial in terms of the study design? And do you think it should be the standard of care for all patients walking into your clinic with muscle invasive bladder cancer?
I think if we look to the group of patients with cisplatin ineligible, previously we don't have a new adjuvant for this group of patients. We cannot give cisplatin. So this group of patients usually we are rely on nivolumab as an adjuvant treatment as immunotherapy. The control group here in this trial didn't include patients with adjuvant or didn't add adjuvant nivolumab in this trial. However, this solving a problem in a special group of patients which is not eligible for cisplatin to give a very effective protocol, either a new adjuvant and adjuvant treatment. For all patients, I think it is not. For all patients, we need to have a criteria for both, either to when to give enfortumab and when to give cisplatin. So it is not for all patients. It is for a special group of patients, and we need to settle a criteria for both protocol.
Okay. Dalia, your thoughts. Should this be the trial or should this be the combination for all patients walking into your clinic on Monday with muscle invasive bladder cancer that fits the criteria? I'm not talking about cisplatin eligible or not eligible, but fits the criteria.
I think this will be the standard of care. We also have the ongoing trial, the keynote EV04 trial also is ongoing, and I think this will be the current practice. This is we are saving the patient from getting the toxicity of chemotherapy. So this is the option of chemotherapy is cisplatin based or MVAC, which are very toxic medicine to patient, and most of these patients have already like renal impairment secondary to either the disease or other comorbidities. So I think this will be the standard of care in the near future. Yeah.
So when you look at the PCR, it was very interesting. You can actually see the PCR significantly increases from using Pembro 8.6% to 57.1% with enfortumab plus pembrolizumab. And in those patients who actually achieve a PCR, you can see that this is a solid green line here, enfortumab plus pembrolizumab. In the control arm, those patients who have a PCR, you can see even though they have a PCR, they're doing worse compared to if you give enfortumab plus pembrolizumab. And the same if they have residual disease, enfortumab plus pembro is better than giving pembro alone. So again, telling us that irrespective of achieving a PCR, the combo is actually better. Now, Dr. Ashur, what are your thoughts and your experience? Because I believe you have good experience giving enfortumab plus pembrolizumab. When you're looking at the side effect profile, what are your thoughts about using it in clinical practice routinely?
For the Enfortu Pembro we are using since 2024. In this protocol, it is not an easy protocol. Most of patients having skin toxicity, most of the patients having fatigue and have peripheral neuropathy. So and hyperglycemia also. I have one patient having all this toxicity at the same time. So, and I have patients with grade 3 skin toxicity. This is limiting completion of enfortumab. So enfortumab is not an easy drug. It needs special attention for the toxicity management and for manipulations of manipulation of the doses for this patient. So it is very important to recognize the toxicity and the limitation of enfortumab before you start in the treatment by it.
Okay.
Can
Now
I have
let's
a
go.
comment?
Yes,
Can I
yes,
have a
Dalia.
comment here? Yeah,
Yes, Dalia.
thank you, Dr. Ashur, for your comment. Yeah, we have experience with enfortumab in the metastatic setting, but also in the I started to use it in this muscle invasive as a new adjuvant approach. And honestly speaking, the enfortumab used in the new adjuvant setting, it's for limited time. It's not forever. So we don't see this long-lasting side effect in the new adjuvant or the perioperative setting as the metastatic approach, as Dr. Ashur pointed out. Yeah,
So,
thank you.
Dr. Ashur, if I may ask, when you use it in the neoadjuvant setting and then you go on to use it in the adjuvant setting, how long can you take it for? The enfortumab.
The new
Yes.
and the enfortumab is given about 3 cycles before as a new adjuvant, then 5 cycles after
Yes, but are you able to give the
the
complete? Are you able to give? That's what I'm asking about. Are your patients able to tolerate it?
until until now we are ongoing. We started to use in muscle invasive as new adjuvant in 2025. We started to use this protocol in this group of patients. We still the patients, we have patients completed the treatment with enfortumab, the 8th cycle of enfortumab completed, and on pembrolizumab. So still we are building our experience in muscle invasive bladder cancer. If we go back to a metastatic setting, we have we didn't exceed 10 cycle of enfortumab. If we reach to 10 cycle of enfortumab, this will be achievement in this drug.
Okay, now let's move on to the next study, which is a Nigara study. The Nigara study was a phase 3 clinical trial. These took patients who were cisplatin eligible with bladder tumors. Again, in the perioperative setting, they were randomized to get Durva plus Gemcis versus Gemcis. Then they underwent surgery, and remember they got 4 cycles. And then in the post-op setting, there was no chemotherapy. They got either durvalumab adjuvant if they had gotten it in the perioperative setting versus observation in the adjuvant setting. You can see that the primary endpoint was event-free survival as well as PCR. So the dual endpoints in this particular study. The patient characteristics were well balanced. You can see that in terms of the PD-L1 expression, high was again the majority of those patients. When you're looking at the event-free survival, again, it favored the group of patients who were getting Durva plus chemotherapy versus chemotherapy alone. Again, you can see the hazard ratio was 0.68. This was statistically significant. And then when you looked at the event-free survival sensitivity analysis, sorry, when you're looking at the event-free survival sensitivity analysis, again, hazard ratio of 0.69. When you're looking at the event-free survival, the forest plot, every subgroup of patient is benefiting irrespective of the PDL1 expression. So, Jamila, what are your thoughts about the study design of the Nigara study? Do you think that the control arm now is better? And where would you place Nigara compared to the keynote?
Yeah, actually, still here in Oman, also we don't have the access to Niagara, durvalumab, but it shows that really adding the immunotherapy to the chemotherapy, it has added benefit and efficacy for these patients. So here, again and again, it seems immunotherapy has to be the backbone, not only the chemotherapy. How now to choose between these and how to interpret it in enfortumab vedotin, which is for all patients. Regardless their renal function, and here it is only for patients with good renal function. So yeah, I
Okay,
mean now
I
I'm
understand.
working hard to get the enfortumab vedotin actually.
So, Dr. Abdurrahman, when you look at the
Yes.
pathological complete response, you can see that adding durvalumab improves the PCR, and you can also see that the overall survival is also improved when you're adding durvalumab to the chemotherapy. So, I heard from the conversations that we've had today that you have given Nigara in your
Yeah.
clinic quite a bit, but I'm not sure if you've given Keynote. Now, you've seen both studies.
Yeah.
Will you use both in your clinic? Will you use one in preference for the other? I'd like to know from you
Yeah.
very briefly because we have 20
Okay.
minutes before to do the metastatic setting. I want
Okay.
to know who you would give Nigara to and
Okay.
who you would give Keynote to,
Yeah,
briefly.
clearly, Nigara is a positive trial, and we have in our practice for those patients who are cisplatinum eligible, the comparator arm was very well balanced, and we have a good pathological response and even free survival. So, patient who is eligible for cisplatinum, we will go with Niagara protocol. Patient who are cisplatinum not eligible, or some patient decline chemotherapy, for example, he don't want to have chemotherapy, then I prefer enfortumab vedotin with pembro, because also, as mentioned early, is somewhat there is some toxicity, but these are manageable toxicity. We have to be a little bit careful and few cycles. So I think that is the way I am using in my clinic.
So, Dahlia, if a patient is cisplatin eligible, would you give Nigara or would you give Keynote? And why wouldn't you give Keynote?
I will give both options are available for me. I think when if I am looking to a response, I think the objective response rate with the keynote 03 or 04 that's coming, I think is very significant. Niagara also is a positive trial based on the pathological response and the event-free survival. So both options are available. But as mentioned by Dr. Zar, if the patient doesn't want to use the chemotherapy, which is cisplatin, or to expose himself to that, so I will choose the keynote 04 or 03 according to the renal function. But it's good to have this option for our patient.
All right, so now let's shift gears to the advanced bladder cancer setting. We have 20 minutes to go through this, and I think there's a lot more discussion around here, I think. But before I go over that, Jamila, I'd like to ask you the question. Before we go into the advanced bladder cancer setting, I want to ask you the simple question. Number one, should all patients in the muscle invasive bladder cancer setting get immunotherapy? Yes or no?
In a metastatic setting, yes.
I'm not talking about metastatic. I'm talking about muscle invasive bladder cancer. I haven't gone to the metastatic setting yet. Very clear question. Should
Yeah,
all patients get immunotherapy?
absolutely,
Yes or no?
absolutely. With
Okay,
all what we saw with you now, I think the immunotherapy is a very important part of their
perfect.
treatment.
Perfect. Dr. Ashur, do you think all patients in the muscle invasive bladder cancer setting, should they get the immunotherapy based regimen in the perioperative setting, or should they all get it in the adjuvant setting?
I think perioperative setting is better according to the available drugs.
Okay. Question number 3, Dahlia. Do you think as of Monday in the clinic, is there any role to determine who gets immunotherapy or not based on ctDNA?
Adjuvant?
Adjuvant, yes.
No, I
Okay.
don't think so.
And and Dr. Abdurrahman, you get the last question for the early stage setting. Which regimen in a cisplatin eligible patient do you prefer, Keynote or Nigara?
Nigara.
Okay.
It's
So,
Niagara.
Oh la la.
Niagara, Nigara, whatever, but it's durvalumab.
But your question,
Niagara, Nigara, I just like the way I say it. All right. So now advanced bladder cancer setting. Dahlia, what do you typically use in the first line setting? Very quickly, because we have so much data to go through.
So you used to differentiate between cisplatin eligible and cisplatin ineligible, but we have now an option that's chemotherapy free for all patients. So I think the preferred option for me, honestly, if the patient didn't use it before, I think until till now, my preference will go for the chemo-free protocol, which is enfortumab and Bimbro, which give a very good response practically as well in our clinic.
Okay. And Dr. Ashur, do you molecularly profile the tissue and do PD-L1 testing in patients with metastatic bladder cancer? I can't hear you. You're muted.
We muted? No.
No, I can hear you
I
now.
think okay. BDL1 is not a routine test for bladder cancer, but molecular testing is a routine test for us for bladder cancer.
Okay. So very quickly, yes or no, Dr. Abdurrahman Zar, does PD-L1 expression influence what you do in the metastatic setting, in the first line setting?
No.
Yes or no?
No.
All right, perfect. So let's look at the EV302 trial. This was a phase 3 randomized clinical trial. It's also known as the Keynote 839. It took previously untreated patients who had metastatic bladder cancers or urothelial carcinomas. These were patients who had never received immunotherapy. So these are PD-L1 inhibitor naive. Now, this is very important, this particular point. They had good EGFR, ECOG performance status was 2 or less. They were randomized to get either chemotherapy that was platinum based up to 6 cycles versus getting enfortumab plus pembrolizumab with no maximum treatment cycles for enfortumab, but a maximum of 35 cycles for pembrolizumab, dual primary endpoints of PFS as well as overall survival. When you're looking at the progression-free survival, you can see a very early separation of the Kaplan-Meier curves. The median PFS actually improves from 6.3 months to 12.5 months with a p-value of less than 0.0001 and a hazard ratio of 0.48. When you're looking at that forest plot, every subgroup of patients is actually benefiting irrespective of the CPS score, more than 10 or less than 10, and irrespective of where the disease is, those with liver metastases, those without, those who are cisplatin eligible versus those who are not cisplatin eligible, every subgroup of patient is actually benefiting. In terms of overall survival, the risk of death was reduced by 50%, with the median OS improved from 15.9 months to 33.8 months. And again, every subgroup of patient is benefiting irrespective of the PD-L1 status. Dr. Jamila, did Keynote 839 change your clinical practice?
Yes, it should be, but still we don't have the access to enfortumab vedotin, but we are going to have it sooner. Okay, still we are using the maintenance after platinum-based chemotherapy, or we use the combination with the nivolumab, but we are going to get it soon.
Dr. Ashur, has it changed your clinical practice? And if so, how have you found using enfortumab plus pembrolizumab in that metastatic setting, in the first line setting, in your clinical practice? Share your clinical practice with us.
I think, as mentioned before, we have used this drug since long time, more than 2 years now. and in clinical practice, is a very effective protocol. It gives a very good response to our patients. Some patients have CR with the treatment, but at the same time, we have a good portion of the patient with grade 3 toxicity. And during the treatment, the patient is suffering, and never patients completed or continued with enfortumab for long period, more than 10 cycles. This is what is clinically practiced. Most of the patients after dose reduction stopped at 10, at 11, at cycle, at 12 cycle. This is the enfortumab dosing now, despite of dose reduction. This is our clinical practice here.
And Dr. Ashur, did Keynote 839 change your clinical practice?
I think the keynote changed our clinical practice from giving platinum with immunotherapy to the non-chemotherapy protocol. And we are supposed to have, this is the first option for us if the patient has no contraindication to give or has no any obstacle to prevent us to give enfortumab, like the skin toxicity, like the hyperglycemia uncontrolled peripheral neuropathy. All this we are counting before starting enfortumab.
Okay. All right. So when you look at the overall survival analysis, they did a very interesting subgroup analysis looking at the cisplatin eligibility. And in those patients who are cisplatin eligible, again, enfortumab plus pembrolizumab was better than chemo. And in cisplatin ineligible, it was also better than chemo. So, Dahlia, should all patients, irrespective of the cisplatin eligibility, get enfortumab plus pembro in that first line setting?
Yeah, I think so. This is a very significant difference. It's zero point 0.5, the hazard ratio in both the group, like whether they are cisplatin eligible or ineligible. And regarding the toxicity, yes, yeah, maybe there is some toxicity, but honestly speaking, for hyperglycemia, it is very manageable by using the diabetic medication and involving the endocrinology team. For the peripheral neuropathy, maybe this is a challenging side effect with enfortumab. I have patient, he received today cycle 19 of the first line Pembro and enfortumab. He's doing very well, complete radiological response, but I have another patient, yes, I'm struggling with the toxicity. But
What
honestly,
toxicity?
I think I mainly the nephropathy. Sorry, mainly the neuropathy. This is the main side effect I see with the enfortumab. Otherwise, the rest of side effects like hyperglycemia, it's controllable with the medication, the diabetic medication. This is the most two or the highest two side effect I noticed with using it.
So my question to Dr. Abdul Rahman Zar, why is it that everyone is calling this a chemo-free regimen when enfortumab is an antibody drug conjugate that's composed of, your antibody and your chemotherapy? So why is everybody calling it a chemo-free regimen? I'm very curious. It's not a chemo-free regimen in my opinion, but why are you Dahlia kept saying chemo free. Dr. Ashur kept saying chemo free. I want to know, Dr. Abdul Rahman, is this a chemo free
I think
regimen?
it is not chemo free, but I mean, it is not
It's
typical like
better.
what we see in chemotherapy side effect,
Hide in
like
I'm
chemotherapy.
just pulling your leg.
vomiting and other. What we have is a different kind of side effect where we see hyperglycemia, neuropathy. That is the two main thing I am facing. We don't have any other issues like, chemotherapy. You get myelosuppression, febrile neutropenia, and all those side effects very
Yeah,
commonly.
exactly.
Yeah, so probably that is why people, they say, because it is anti-drug conjugate and the chemotherapy itself go to the tumor cells and then it start working, not like in all cells, probably. If
So can
Yeah.
I ask Dr. Ashur, since you have the most experience with enfortumab, do you get your endocrinologist on board to, knowing that the hyperglycemia is going to be an issue? Do you get them on board from the very beginning?
Yes, if the patient is diabetic and with the treatment and hemoglobin A1C is high, or during the treatment blood sugar is uncontrolled, usually we are involved in diabetology with us in management.
Okay. So when you're looking at the duration of response in this study, you can see the among responses, the probability of a maintained response at 24 months was actually approximately 50%. You can see that complete response was actually achieved in 30.4% of patients who got the combo of enfortumab plus pembro versus 14.5% who got only chemotherapy. Dalia, if I may ask you the question, had this trial incorporated immunotherapy together with chemo in that control arm, would we have seen the same results?
I
Because
think
I'm coming to that in the next study, so that's why I'm asking you the question.
I think using the chemo plus immunotherapy, there is, I think, data I cannot remember, but
I'm coming to it. I will remind
yeah,
you about the data.
okay,
Don't
come to
worry.
it, please.
All
Okay.
right. Okay. So my question to Jamila now, I know you don't have enfortumab, but we talked about perioperative use of enfortumab plus pembrolizumab. So you can use it in the perioperative setting, you can use it in the metastatic setting. Say suppose your patient has actually received it in the perioperative setting and then relapses. What do you do for that sort of a patient in the first line setting?
I will do as usual. My colleagues, when they say, is it 12 months or after 12 months? And then, yeah. Otherwise, we will make as it is. We start from the beginning. We give the chemotherapy, and then if the patient is doing well and he is not progressing or good response, we can give the immunotherapy as maintenance. We start as if we are setting the clock from the beginning. Maybe that is, but there is no data, and we don't have anything from the real world also, what they are doing after this. So maybe later on we will get what our colleagues already doing for the patients who are progressing on antibody drug conjugate with immunotherapy.
Doctor, sure. What would you do if your patient got perioperative enfortumab pembro and then relapse? First line setting. What the hell are you going to do with that patient?
If the patient relapse, like Dr. Gamila mentioned now, if the patient relapse after a long time, we can give enfortumab pembro again. But if it is early relapse, I will give chemo, then chemotherapy, platinum.
Okay. So, Dahlia, there was a subgroup analysis of this trial that looked at where the disease was. You can see the site of origin, whether the patient had lymph node metastases or not, whether the patient had visceral mets or not, or whether the patient had liver mets or not. Does any of this guide you to say which patient should receive enfortumab pembro versus chemotherapy, or do you believe all patients should be receiving it?
All patient, the patient I'm talking about who's getting 19 cycle of this protocol, he had liver, lymph node, and plus the locally advanced disease. So all of them.
Okay. So, Dr. Abdulrahman, we also have data of those patients who are older, more than 75, with many comorbid conditions, including diabetes, including a low EGFR. And you can see that even those patients with diabetes, and this is something that you worry about because you can get hyperglycemia with these patients, they're still doing much, much better than giving chemotherapy. Those patients more than 75 years also doing much, much better than giving chemotherapy. And those patients with low EGFR also doing much better. So, do any of these characteristics deter you from using enfortumab plus pembro, or do you think that it doesn't matter even these poor prognostic, it's not prognostic, but poor, factors that make them actually have side effects? Do you think that this is not a problem with enfortumab plus pembrolizumab?
I think, as per the clinical trial, also, if hemoglobin's 1C level more than 8, those patients were excluded. So I think if the
Yes, yes.
sugar control is not very good, I am not going. If patient 75, good performance, good renal function, I will still consider. But otherwise, for those of my patient, and I have almost last year, I have couple of them, I just use a single agent pembro.
Now, if I may ask the question, Dahlia, how often have you seen, because the most important side effect is rash and peripheral sensory neuropathy. There is hyperglycemia, but it's not as important as the peripheral neuropathy and the rash. So, how often have you seen it and how have you managed it?
Which one? The rash?
The rash and the peripheral neuropathy.
Peripheral neuropathy, it's very common. I saw it in the enfortumab as single agent in second line. I saw it with enfortumab and pembro as a first line. It's significant toxicity, and it reached me to grade 2 or grade 3 in the patient I'm talking about. But I honestly, what I am doing, I'm starting the vitamin B complex. I'm giving now Simpelta. I'm involving the neurology team in board as well, just to help me to overcome. I dose reduced at the beginning with the rising blood sugar, and the patient maintained. Honestly, the patient I'm talking about, this patient, he started to have the complaint of losing taste sensation. He lost the taste sensation, but by time it improved. And by the way, this patient also has only one kidney. So you can imagine this patient, this is the only option, and honestly, because I want to save this kidney as the other kidney as well. So this is how I manage the side effect. When
Okay.
it comes to rashes, it happened with the patient, but it was very controllable with just conservative treatment and local measures.
So in the last couple of minutes, want to give you the last trial in the metastatic setting first line, which is a Checkmate 901 study. Again, a phase 3 clinical trial. These were untreated metastatic bladder cancer or urothelial cancer patients. These were cisplatin eligible patients randomized to get Nivo Gem Cis versus Gem Cis. So good, control arm that gives you, correct information. And of course, here the GEM-CIS was given up to 6 cycles, followed by maintenance nivolumab. You can see overall survival is the primary endpoint. These patients did benefit with the addition of nivo to that chemotherapy. Every subgroup of patient is benefiting. You can see the progression-free survival also improved with the addition of nivolumab, including the duration of objective response. So, Dr. Ashur, you have 2 trials. You have the Checkmate and you have the Keynote. What are you going to use, enfortumab pembro versus gemcis pembro, in your cisplatin eligible patients? Very quickly tell me.
Enfortumab pembro.
Please tell me why, very quickly. Is it because you have too much money and enfortumab very expensive? But you tell me why you would give enfortumab
according to
plus
the
pembro.
I think the overall survival for checkmate is less than the overall survival for
So
chemo.
this is the slide you're
That
talking
is
about, Dr. Ashur, where you have a comparison of Checkmate 901 versus the Keynote study, and you can see hazard ratio 0.78 for Nivo Cis Gem versus 0.47 for enfortumab pembrolizumab. But you really need to look at that median. The median, you can see Nivo Cis Gem is 21.7 months, while 31.5 months. I completely agree with you. The overall survival looks better in the enfortumab pembro, but it's not a head-to-head comparison. So I'm playing devil's advocate here. It's not a head-to-head comparison. So convince me why I need to use enfortumab pembro as first line and not nivo gemcis, which would be significantly cheaper.
I think also the inclusion criteria for checkmate, they are choosing the patient with
Control arm.
good quality of patients, good performance status, renal function is good, cisplatin eligible. So the criteria, eligibility criteria is different than the eligibility criteria of patient with keynote, which is more frail patient than patient. So and also as you see here, the control arm is different between
Totally different. I think for
both.
me, when I look at it, Dr. Ashur, please correct me if I'm wrong, and Dalia and Abdurrahman and Jamila. If you have a patient that's cisplatin ineligible, it's a no-brainer. It should be enfortumab plus pembrolizumab in that first line setting. That is set. If you have a patient that's cisplatin eligible, you have the choice of gemcis nivo versus enfortumab pembrolizumab, but clearly enfortumab pembrolizumab has a better overall survival, and you're having more patients that actually can get that maintenance immunotherapy. in the maintenance setting. Dalia, what are your thoughts here?
Uh, yeah, as you mentioned, this is my choice. But honestly, I have a question. If I need your opinion, all of you. So, if the patient with this type of medicine and he had toxicity from the enfortumab, but especially the neuropathy, so would you stop it and keep the pembro maintenance therapy, or what do you do, Dr. Ashur, for example, or Dr. Shahina, Dr. Zar, Dr. Jamila?
Dr.
Usually
Sure,
we're
tell
stopping
us.
the effort. Usually we are stopping the effort and keep the PIM.
Pembro. Okay. Thank
Yeah,
We have a couple of
I
like this.
Yeah, I also we if we see that it is not tolerable, neuropathy is getting worse and getting more than grade 2, then we stop infirtumab and maintain them on pembro if he's tolerating. And see, I have patient who is on pembro, almost completed now, more than 1.5 year, and he has almost, we can say, complete remission with liver and lung metastasis.
Yeah, thank you so much.
All right, so I made it on time. We talked
Thank you.
about everything from muscle invasive to perioperative. So, thank you so much. I think we've had a very interesting discussion. I think there's so many questions that we could have asked, but unfortunately, that we were limited by time. But I think we had a very interesting discussion. Thank you, Dr. Jamila. I know you were on your way home, but I made it on time, 1 minute over time. Thank you very much, and I'll meet you all at the next edition of the EIOC Journal Club.
Thank you, Shahina. Thank you all. Good night.
Bye,
Bye
bye, bye,
bye.
bye,
Bye
bye,
bye.
bye, bye.